All right. Good morning, Flagler County. This is Danielle Anderson, your host of Lifeline, the radio show connecting you to positivity in our community. And we have Dr. Kunal Panwar in the studio. Is that right?
That was perfect.
Oh
Better
my-
than my parents.
All right. I have to tell you guys, I'm cheating. If you're watching us on Facebook, you're going to know what I'm doing. He was amazing and actually phonetically spelled it for me. It's awesome meeting so many different people, and everybody just brings a different level of spice and flavor to the table. And you are bringing what to the table?
Yeah, so I'm a new orthopedic surgeon here. I do adult reconstruction, which is the fancy way of saying hip and knee replacements. I don't know why we came up with that word in the orthopedic community, but it's adult reconstruction is the subspecialty. And so that is predominantly, again, hip and knee replacements. There's a lot of different joints in the human body, and orthopedists have kind of subselected different ones that have similar problems and different surgical approaches or pair well together. And hip and knee has to be, one of the most common sources of arthritis. So that's mostly what I do, and that'll be both, primary joint replacements, meaning if you have arthritis, you've never had any surgeries before, and it's causing you discomfort, or if you need a redo operation. So that would be something called like a revision, hip or knee replacement.
Why do you think those are the two most common things to wear out?
Yeah, I mean, there's a lot that goes into it, but in general, we walk on our lower extremities, and we're not, whether or not you follow the idea of upper extremities as an ambulating, joint reactive forces, we don't really have any stress on the upper extremities in the same fashion. So knees are the most common source of arthritis, and it's an interesting joint too, in that it's not a ball and socket joint, so things slide, rotate, and pivot. So it's susceptible to some unique stresses, and for whatever reason, that seems to be the most common joint that we get arthritis.
So how come our ankles don't have those same kinds of problems?
Yeah, that's a great question. Ankles are a little different. It's a very constrained joint. So it is a hinge joint like a knee, but the actual motion in the ankle joint, like when you roll your ankle or you're twisting your ankle, it's coming from the adjacent joints too. So the ankle is in and of itself very constrained, meaning it doesn't rotate and twist to the degree that the knee does. But when you do have those moments or twisting injuries or instability in the ankle, it's most likely coming from the ankle joint or the joints below it and adjacent to it. So there's a lot of other joints in the foot that contribute to that increased flexibility and distribute some of that stress. But the knee is the only thing between the hip and the ankle. So everything that goes through your mid-axis of the lower extremity goes through the knee.
That's a good point. So, I mean, it is high heel season. Let's talk a little bit about women. How do high heels contribute to these kinds of things?
As far as I can say, evidence-based, there's not much. I mean, high heels for
Really?
sure in terms of knee pain and hip pain, not a big thing. It's now, I have very limited experience wearing them, so I'll admit I've tried. It's really impressive that, y'all are able to get around as well. It's a lot harder than I thought it would be. But, I mean, high heels have their own unique problems, I would say. Your foot isn't designed to necessarily have your toes crammed together. But from a knee and hip side, it's totally fine. It's fashionable. I understand the desire to wear them. Can't say that it'll cause arthritis or any trouble. It can cause some issue in your toes. You can get neuromas, other sorts of problems. But, if it's comfortable and it fits well and your toes aren't crammed together, go for it.
That's awesome. Great news for all of us shoe wearers getting ready to hit the New Year's Eve parties. So how did you get into this field? I mean, what made you decide? Where did you come from?
So I did medical school, was all the way in Texas. So it was at University of North Texas Health Science Center, and that's in Fort Worth. I actually was an EMT for a while. So when I was in college, I did a little bit of everything. So, my mom's a physician, so my parents were okay with me doing quite literally anything. And I thought for the longest time that, hey, I'll do anything besides become a doctor. And so, my freshman year in college, I worked in a little bit of finance. And so I spent some time at a bank, and I did like a little summer internship, and I was looking at doing something in the line of investment banking. And after a couple months in that, I was like, this is miserable. There's no satisfaction here. You're just kind of, no offense to anyone in that line of field, but it wasn't for me. I didn't find it like gratifying. I took an LSAT the next year, and I thought I wanted to be a lawyer. And one of my best friends, his brother was a lawyer, and he for whatever reason is the most pessimistic lawyer I've ever met. So he deterred me completely from that. Even though I loved the test, it was very like logic driven, and it definitely was something that I thought I would be really interested in. long story short, halfway through college, I wasn't sure what I wanted to do. I was a math and chemistry major, and I liked science a lot. And I thought I wasn't ever going to become a doctor. And then I got an EMT license, and I started, driving around on ambulances in Atlanta and taking care of people. And I was like, this is really cool. I want to go to medical school. So that was my first foray into medicine. And then, even in medical school, I didn't know anything about surgery or orthopedics. Most of medical school, we study like, general ailments of the body. Everyone's familiar with high blood pressure, what is diabetes, and how does your blood sugar affect different things. And all of that was well and good, but about halfway through med school, I got my first dabble into orthopedics, and that was really rewarding for me. A couple reasons. Number one, uh, not everyone cares about their blood pressure or their blood sugar, right? I mean, it's important, but it's hard to be invested in it. It's just a number a lot of the times. But, when someone breaks a bone or has a physical ailment that limits their ability to get around, it is universal. I don't even need to speak the same language as someone. I can show them an x-ray and they'll understand this is not normal. So I really like that because people were invested in getting better, and I think that's like 90% of medicine. So that was a field that gravitated to me. And then as I got into the science of it, right, I was a math and chemistry guy. I loved physics. If I could figure out a way to get that involved in my career, I would. And orthopedics is like very much about mechanical engineering, angles, load distribution. How do we design implants? What's a good way to fix a bone straight or crooked? And why does it not work in certain aspects? So it was perfect for me. So I kind of fell in love at that stage. And then as I got further into it, I just became more obsessed with it.
That is awesome. So where did you go from there after Texas?
Yeah, so
Just
after
in Atlanta?
Texas, yeah, no, actually. So after Texas, I did my residency in California. And so that was called Valley Orthopedics. And so that was in the Central Valley in between Modesto and Stockton. And so I was mostly just trauma centers for 5 years. And so we would just take care of people who had really bad injuries, highway accidents, you name it, motorcycle crashes, a little bit of everything. People call it the meth valley of California. There's a lot of people who, uh, do meth and then get on the highway and get on a car, and you're allowed to legally split lanes. So it was a very heavily trauma-heavy residency program, and I loved every bit of it. I had a lot of opportunity to learn about orthopedic trauma and how do you tackle these different problems. And for the longest time, I thought I was going to go into traumatology, but throughout residency over those 5 years, you do a little bit of everything. And joint replacement was like constantly the most gratifying thing to me. And people do very well. The operations, when indicated appropriately, people can be really happy after joint replacement. And it was the same reason I wanted to become a doctor. I want people to be invested in their care, and I want to do something that people have a signified and quantifiable benefit from. Not to say that taking care of your blood pressure isn't important, but it's harder to be as invested in it.
That's really cool. I mean, I've interviewed a dozen doctors. I have never heard anybody say it like that.
Oh, thank you.
Because you're invested in the outcome.
Yeah, it's great. I mean, it makes a big difference. I mean, it's fun to see. It's addicting, honestly, when people have a problem and they feel better and they're walking. It's really satisfying. Yeah.
What's been the most challenging case for you?
It's a good question. I mean, I can't go into the details, but we have a lot of people in this town or I would say in this community in general, who've had joint replacements, and joint replacements fail for many different reasons. As much as we like to think they're the perfect operation, things have changed a lot over the years. So I would say the most complicated problem is when we deal with infections of a joint. There isn't a simple solution to those. Frequently requires more than one operation. A lot of the times it's a tricky problem in terms of outcomes too, because despite our best efforts, there's a high recurrence rate of these. So I would say hardest thing for me has been some of the infections we've dealt with. You have a lot of bone loss in those situations too, and it can be difficult to reconstruct the joint when there's nothing, no foundation to work with.
Are you in a point where you're using like 3D stuff to kind of fill in those gaps?
Yeah, so this has been like very interesting to me too. If you look at like the history of joint replacement, so there's a guy called John Charnley, who is the forefather of total hips, and he really laid down the framework for how do we mechanically do a hip replacement. Because if you look at this, like people have had arthritis since the beginning of man, right? Our lifespans have gotten longer and longer, and as a result of that, the disability of arthritis becomes more and more pronounced. So if you look at like the 70s and 80s, when we would do hip replacements or joint replacements in general, like the most rudimentary ones where we would literally take like pig fascia or the IT band and we'd cut it and we'd stick it inside the joint as like a cushion.
Wow.
And we used to do like numerous different implants. We've put glass into people's joints. We've put wood into people's joints. Dr. Charnley has a series on when we use Teflon as a bearing surface. So Teflon, we know it's smooth. It's allows for easy articulation, and the thought was that that would be a frictionless surface and it would be safe for people to walk on. It didn't work very well, and so he had to go through a lot of trial and error to get to where we are today. So, to answer your question in a roundabout way, there's been so much development and really, really rich history of how have the forefathers of joint replacement gotten to where we are today. So today we have numerous different implants and technologies that are available. There's a lot of 3D printed metals that are designed to grow into your bone.
Wow.
We can design implants based on someone's unique anatomy. You can get a CT scan and get a very specialized and patient matched, reconstructed implant in unique circumstances. So there's a lot that's developed in this realm, and it's come a long way from when we were sticking plastic and, pig tissue into people's knees to try to get them to feel better.
So do we have those capabilities here right now?
Yeah, absolutely. I mean, all those things exist. We can accomplish that in a variety of different ways, but absolutely. I mean, routinely we're using different 3D printed metals for joint replacement at Advent Health, and those, we can scale that to any degree, so that all that technology exists.
That's incredible.
Yeah, it's really crazy, especially with the historical perspective. I mean, to me, it's still like I look at these and I look at the textbooks that we studied and how things were done and how they're done now, and it's really changed a lot.
That's amazing. All right, so we're going to take a quick break, and we're going to come right back to Dr. Panwar and see who his ideal patient might be. We'll be right back.
Sure.
That's crazy.
Yeah, it's
Have
nuts.
you seen all those things since you've been working?
Yeah, I mean, there's some things I haven't done yet. I mean, I've only been in practice for a couple months. We did we did everything in New York. So that was the purpose of a fellowship. You kind of see a little bit of everything. So over my 1 year in New York, we did all the different combinations of every crazy implant that has ever been made and used in people. So I have a whole photo album full of crazy things that, yeah, I mean, it's just like interesting to see how those things work and play out, and how do people do after, which is actually like, you look at an x-ray and be like, man, how does that person even walk? And you see them walking down the hallway, great, happy, you're like, oh, this is crazy. It really looks like a Frankenstein experiment. And then when it comes together, it's a beautiful thing.
That's crazy. So we're back with Dr. Panwar, and we're talking about his ideal patient, and he does not make people look like Frankenstein. He gives you a new lease on life.
Yeah.
And that's really what it's all about, is restoring people to mobility, right?
Yeah, absolutely. So it's about taking care of pain. That's the main reason why we do these things. If pain is your limiting factor and you have arthritis, a joint replacement is absolutely something you should consider. There's a lot of things short of surgery that we can cover in detail. I mean, we have injections, anti-inflammatories, weight loss, assistive devices, therapy, you name it. A lot of the times when we're looking at people who are considering a joint replacement, they are people who are active, still, trying to, whether that's go on walks or hikes with their loved ones, chase their grandkids, go to the grocery store. These are people who want to get back to that activity status, and they're limited by joint pain. Generally speaking, these people, the perfect patient for a joint replacement would be someone who has severe arthritis, who's failed all the non-operative measures, and still maintains a very active lifestyle and wants to continue that. Those are, in my experience, are the patients who do the best. Again, people who are pretty invested in maintaining their quality of life and really want to, maintain that aspect.
We have a very active community here. We've got pickleball, walking, biking, just huge recreation in our community. So how long, when someone starts to experience those really severe symptoms, do they have to wait before they can get under?
Yeah, it depends. So a lot of the times, if it's a new onset problem and you haven't, had a doctor get an x-ray or even had it worked up, I'd say like 60 to 70% of the people I see, I'm starting them on all the non-operative treatments. And frequently, that's all you ever need. I mean, there's a lot of patients we take care of who only need a couple steroid injections at worst case scenario, or they respond really well to anti-inflammatories and therapy. If it's severe and you failed all those other things, that timeline can vary from person to person. It depends on, a lot of other factors that go into it. Some people can't take different medications for
Yeah.
medical reasons. Some people are just totally averse to needles, and I totally respect that. I have yet to meet anyone who says I'm a fan of needles. So, um, but yeah, I mean, it's a difficult question to answer directly. I would say on average, usually about 6 months is the earliest of non-operative treatment that we're really looking at considering some sort of surgery.
So we talked to Dr. Cascio last week, and he kind of talked about the failure rate of breast implants,
Yeah.
and the fact that people didn't know that. What is the longevity? What's the shelf life of a replacement?
Yeah, so it varies on the hip and the knee side. And this is a really good question that is changed a lot over the past decade. When we look at hips, so you have to ask yourself, like why do these not work anymore? So I gave you that historical perspective of when we were using Teflon and different parts. Um, these days, 95+% of hip replacements are designed with implants that are designed to grow into your bone. So we're no longer using cement to hold everything together. There are circumstances where we do still do that, but for the majority of hip replacements, it's titanium implants that grow into your bone. And then the bearing surface, which is where the two components of your hip joint rub on each other, is predominantly a ceramic head on a highly cross-linked piece of plastic. And so that bearing surface is extremely well studied. And so there is very, very little wear of the plastic. Prior to 2001, we had an older design of plastic. Now we have good 20 and 25-year data on plastic in very young active people, and we can say with confidence that the plastic should outlive a normal human. So when I answer that question, I give a roundabout answer because there are reasons that hip replacements fail still. I would say infection, or if you break your femur, or you have recurrent instability where you're dislocating, are the most common three. But in the absence of those, a well-positioned hip replacement can outlive a human. So we have changed the indications to as young as in New York. I was part of cases where we did them on 20-year-olds, right? So
That's what I'm hearing, because people are saying, let me wait a little bit longer so I
exactly.
don't have to do this again.
Exactly. And so that was the old school way of going about it. But the data has become pretty clear now. And again, these implants that we're using now have been around for long enough where we can say with pretty good confidence that it's safe to do it in younger and younger individuals. Same thing on knees. So press fit implants, where the bone grows into them, have really become popularized over the past decade. They've been around for much longer, but the data, as more of it comes out, and we're seeing that these implants are not failing like they have historically, people are just getting more confidence that this is a safe thing to do and offer patients. So same thing, we do still cement a lot of knee replacements. I would say knees are cemented much more frequently than hips. But when you use the cement, that bond between the cement and the bone only lasts. It's the best of the day of the surgery. Every step you take, it dwindles. So that's one of the reasons why we would get that old number of knee replacements only last 20 years. These days, if you're using press fit, in the absence of infection or any instability and you don't break any bones, it could last theoretically a lifetime. So it's the same theoretical benefits, but there's caveats to this. Everyone's a little different, and sometimes you're not a candidate for some of these different kinds of knee replacements. But in the perfect scenario, it could last a lifetime.
Talk about recovery time. That's a big one.
Yeah, that's huge. So when we talk about recovery, the two studied ways that people talk about it is called the patient acceptable symptom state. So PASS is one. I like to just look at the literature from a standpoint of how long does it take for people to get better than they were before surgery. So if you need a hip replacement today, how long on average will it take for you to get that acceptable symptom state and be better than you are now? And so it varies study to study, but for a hip replacement, it's a little quicker. It's usually closer to 4 to 6 weeks, where you can have that recovery be meaningfully, impactful. Where you're, hey, I feel better than I did before surgery. For knees, it's closer to 3 months. So knee replacements do take a lot longer to recover from. We do a lot of partial knee replacements as well, and those are actually a lot more analogous to a hip replacement. The recovery is really fast. It's a much more natural implant, smaller incisions, less metal. But I would say on average, knees you can expect about 3 months, and hips it could be as quick as 4 to 6 weeks.
It seems like hips would be a major surgery and would keep you down for a long time.
Yeah, I mean, I think that's a big shift too. Is there's been a huge trend towards doing these surgeries with more muscle sparing approach. So people in the orthopedic community debate about this a lot, and I think it's maybe a little more hyped than it actually is. But yeah, I mean, the anterior hip replacement, which is where you make an incision through the front, it's more muscle sparing. It's my preferred way of doing it. Has gained a lot of popularity, and people have been very happy with how those operations do. Frankly, the recovery is really nice, and its benefit over a traditional, more or less muscle sparing approach is debated a lot. But there's some studies that show that you get around quicker and you recover faster, which is really the most important thing.
And sorry, a little bit of the vanity issue here.
Yep.
What's the scarring look like?
Yeah, it totally depends. So some people aren't candidates for that anterior hip replacement. I mean, it can be done in a pretty small incision. So that's the fun part about it is if you are reasonable body weight and you have good muscle tone and you don't have any significant deformity on your X-rays, it can be done in as small as a 5 to 6 centimeter incision. So you can get these things done in pretty cute ways, if you will.
Right.
Knee replacements in general. It's harder to get that done through a smaller incision, but it can still be done. There's people who accomplish that really nicely.
That's amazing. I'm like, all right, this doesn't seem like so bad after all.
Yeah, there's a lot of misinformation, I think, that gets around on these operations. And, I think at the end of the day, it's still an elective thing. You do it when you need it. So there's no one is ever like, I never tell anyone, you need to have this done tomorrow. It's like, it's your joint. If this is something that bothers you and you have tried these other things and they aren't working, then this is something you should consider. So that's a big thing for me. And then you couple that with where's the misinformation on where do people think they are. I mean, everyone knows someone who's had a joint replacement that didn't do well, unfortunately. We all know someone who didn't have a good time. And it's hard to take those cherry pick cases. And if it's someone you're close to, I mean, that sticks, right? So you're like, if your neighbor's like had a bad knee replacement and they're like, never do it, wish I never did it. It's hard to like go through that if you're living next to someone who's had a bad time.
Yeah.
And it's important to just have that conversation, right? And I have those all the time in clinic, like on a routine basis. These are the things that we do differently. These are the things that are still risks with surgery. And these are the risks. I wish I could tell everyone and guarantee where they would be. But, every time we get in a car, there's a risk to it too.
So what are some of the things, just in general, when someone's considering a knee replacement or hip replacement, when they're interviewing a surgeon, a potential surgeon, what are some of the things they should be asking about?
Yeah, that's a great question. I think there's a lot of different pieces to this. I would say in general, like a more senior surgeon is always a good thing. So, I'm a young surgeon, I'll admit. I haven't been in practice for as long. It's not a bad idea to have someone with a little more gray hair. That comes with a caveat at the same time, because I think when you're younger, you're more likely to stay up to date on the latest research. And I think there's a big benefit to that gets a little undersold. So the colloquial wisdom is go to the guy who's been doing this for the longest. I don't think that's necessarily a bad piece of advice. You're going to get a very consistent outcome. But if you're interested in learning more about what's changed in the field, it might not be a bad idea to see someone who's younger. I do think it's really important to pick someone who's fellowship trained in what they're doing. I think the days of having orthopedists who do a little bit of everything have come and gone. 20, 30 years ago, you'd have a guy who would do carpal tunnels, shoulder replacements, a little trauma, a little hip replacement, knee replacements, ACLs. I mean, quite literally a jack of all trades. We've gotten a lot of research on these subspecialties, and people have really dived into doing just one or two things really well. And I think it's important to try to find someone who just does one or two things and has a fellowship training in that. I think that is definitely worth the extra time.
Kind of makes you like an expert in your field.
I think it makes a difference. Finding someone who also does revisions or when those operations don't do well is important in my opinion. I think you get a different perspective on these things, and it definitely changes the way I address some of these problems.
That is awesome. Okay, so fun fact:
Yep.
what's your New Year's resolution?
Oh, I
Have you
haven't
made
made
one?
one yet. I haven't even thought about that. Yeah, you got me on the spot. I don't know. It might be. I always try. I don't know what it'll be. It's a little early, but I usually try to cut out sugar for a period of time. Really hard to do, but I wish I could stick to that longer. I usually try to get at least 2 months, but it finds its way in, especially at the hospital. There's always something sweet hanging around.
Donuts, Fruity Pebbles, you name it, it's there. That is awesome. So if people want to get in touch with you, how do they find you?
So I think the easiest way is to just call our clinic. It's definitely the fastest. So I have a phone number. Is that
Yeah,
Yep.
please.
So it's 386-232-9210.
And are you at the hospital?
Yeah, I'm at the hospital.
The
At
main campus or
main
Parkway?
main campus, right down the street. And my office is on the second floor, and we're open anytime.
That's
Give us a
awesome.
ring.
Just really quick, how did Advent Health, how were we able to snag you and get you
Yeah. So uh, I told this story to someone recently, or I heard this when I was traveling. So somebody told me, "You're born where you're born, but you're going to die where your wife is born." So that cracked me up. And basically, what happened is I was looking to stay with my training program in California. I liked working in California, and my residency director really liked having me as a trainee. And so we were kind of doing a little tug of war between my wife and I, who's also a physician here in Florida. And she won that one big time. So I started looking for jobs in Florida, and Advent Health stood out to me big time as a unique employer. They really take care of us, and they're invested in all the right things for patient care.
That's amazing. We're really glad to have you here. Welcome to the community.
Thank you so much.
Awesome. And if you guys have any questions, tell them one more time. What's that phone number?
Yeah, absolutely. That is 386-232-9210.
All right. And we'll be looking forward to seeing some good work from you.
Thank you.
All right. We do want to thank WNZF News Radio, Flagler News Weekly, the Vigilante Philanthropist, Massage by Natalie, and our Benjamin Moore Paint Store right here in Palm Coast for sponsoring the show. You guys have a great New Year.